I would like to ask the second speaker on the podium. Dr. Niklas von Aes, coming from the Royal Marsden Hospital from London. He is chairing the SBRT program at the Royal Marsden Hospital. He's also the co-chair of the UK SABRE Consortium. And you know he's traveling with enormous speed and pace. So he will give you insights into the modern developments of radiation oncology, and I guess in particular also into the field of hyperfractionation and your PACE trials and how they're going to developing and how that is going to move the field of radiation and uro-oncology forward. Thanks, Niklas, for coming.
Thanks very much for the invitation. So when I was asked to give this talk, I was asked to cover modern technologies, hyperfractionation, stereotactic radiotherapy, and imaging, everything you can think of. I thought, well, I can do 30 minutes on all of those topics, but putting it all together is going to be quite challenging. So I hope I've covered what we want to cover, but please ask afterwards if there are any questions. So a few disclosures. So where did we start? Well, this is actually quite a famous photograph from Stanford of one of the first patients to receive radiotherapy with a linear accelerator. And this was a child with a brain tumor. And as you can see, essentially the radiation was just directed slightly towards the child. There was no precision at all. If the child decided to lie down, the tumor would be missed. If the child moved, they'd treat most of the spine. But that was genuinely how the first radiotherapy treatment was given. So what has changed? Well, luckily quite a bit. And the hardware has changed dramatically. This is just an example of some of the different machines we have now. That's a CyberKnife and a true beam linear accelerator, a tomotherapy, and then a linear accelerator with an exact track system on board to allow for tracking the patient. So the hardware has changed significantly, but really it's high-powered computing and software that has really changed our planning, our algorithms, and our ability to calculate dose and deliver dose. And this is really the kind of patterns that we can now do. We can shape the radiation in almost any configuration. We can minimize the dose to normal tissue and deliver high doses to the tumor in a really complex fashion. So this is an example of a new CyberKnife machine. So at the Royal Marsden, we now have 2 of these. We've just installed this version, the M6. We had the previous version. So we now have 2 machines. The difference with this machine from a standard linear accelerator is that instead of the linear accelerator being mounted on a fixed gantry, it's mounted on a robotic arm, the robot arm, just like you'd see in a manufacturing plant. And it allows you to deliver radiation from multiple different angles with a very precise pencil beam or a modulated beam. And this is just an example of how it works for lung cancer. So the tumor, on the ceiling are KV imaging devices with a detector on the floor, so you allow real-time imaging, and then that's fed back to the robot. And as you can see, that beam moves in synchrony with the breathing. So the breathing is modeled, the beam is modulated by what's called a multi-leaf collimator, and the LINAC moves in synchrony with the breathing, and the radiation is only delivered when the tumor is in the path. And the next and really exciting machine is the MR LINAC, and this is made by Elekta, and it's called the Elekta Unity. And what this machine has done is put together both a linear accelerator and an MRI on the same gantry. Now, I'm not a physicist, but it's an extremely complicated thing to do, to deliver a radiation beam through a very strong magnetic field. But it has been successfully done. We were one of the first centers in the world to have an MR LINAC, part of what's called the MR LINAC Atlantic Consortium, which is 7 centers. And we're now treating patients on the MR LINAC in various different clinical trials. And really, what are the advantages? Well, ideally, as you know, CT gives us reasonable soft tissue definition, but MRI is significantly better, particularly in complex areas like the pelvis. We can see the prostate on CT, but we can see the prostate significantly better on an MRI scan. So we can now potentially view the patient in real time while the beam's on. You can image the patient. So currently we are now doing a sort of plan of the day treatment. So every day the patient has an MRI scan, and then one of our doctors, Alison Tree, is leading this work for the prostate work, and one of Alison's fellows will come and recontour the prostate based on the day's MRI and replan, and then the patient has the treatment. But potentially, and what we want to have is real-time adaptive planning. So as the prostate moves, you can adapt in real time. Now, we're not there yet, but that's the concept. So here you can see a verification MRI, then what happened to an image whilst the patient was on treatment. You can see that the rectum changed significantly, resulting in movement. And then afterwards, it looked pretty much back to the original. So if you just took the before and after, you'd be completely reassured that nothing happened while the beam was on. But actually, in reality, there was movement while the beam was on. And these are things we've not really known because we've not been able to test them. And this is an example of an initial MRI. You can see that the prostate outlined in red, and then the target volume in the pink. And the verification MRI shows some movement, but that the prostate is still within the planning target volume. But on another occasion, it moved significantly more, and you can see the white arrow on the bottom of the right image shows that just the prostate is now just moving out of the target volume. So you potentially are missing the area you want to treat. So what have these technologies done for us? Well, really, they've allowed us to think differently about how we deliver radiotherapy. Essentially, precision allows us to target higher doses to the target, and then we can use hyperfractionation. So hyperfractionation just means giving a larger dose per day. So where are we currently with hyperfractionation? Well, in prostate cancer. Well, moderate hyperfractionation, so traditionally we treated prostate cancer with 1.8 to 2 gray per day over 7.5 to 8 weeks. But there are now 4 very large randomized trials looking at going up to about 3 or 3.4 gray, so higher than 2, but not very high, and treating over a 4-week period. So there's the CHIP study from the UK led by my mentor David Dernley, and then the PROPHET study from Canada, the RTOG 0415 from the USA, and the HYPRO study from the Netherlands. I'm not going to go through all of them, but I'll just quickly go through the CHIP study because it's the largest. So it was all men had 3 to 6 months of hormonal treatment. They were T1B to T3A, estimated seminal V scores less than 30%, and all had PSAs lower than 30. And they randomized between what was our current standard dose, 74 gray in 37 fractions, to 2 experimental doses, 60 gray in 20 fractions and 57 gray in 19. And both of those fractionations were delivered over 4 weeks. It was a very large study, 3,216 patients. The median age was 69, predominantly intermediate risk patients with a small number of low and high risk patients. And it was designed as a non-inferiority study. So this was the control arm. The 5-year control was 88.3%. Now, when David Dernley designed the study, he expected the 5-year control to be 75%. So the overall control was significantly better, and it meant that the study had to go for longer, and we had to grow the numbers because the event rate was much lower than we expected. We were not expecting 5-year control of 88%. This is the control arm. And the 2 experimental arms showed the 60 gray was 90%, and the 57 gray was just a bit lower and did not demonstrate non-inferiority. So 60 gray demonstrated non-inferiority to 74 gray, whereas 57 gray did not. So what about profound hyperfractionation, or what we call stereotactic radiotherapy? I mean, can we go above 3 gray per fraction? In radiation biology, there's a concept of the alpha-beta ratio, which is essentially the cell sensitivity. And the lower your alpha-beta, the more you're going to benefit from high fraction size. And there's now pretty robust data that the alpha-beta ratio for prostate cancer is low, and we think it's somewhere in the region of 1.5. And that shows if you deliver 36.25 gray in 5 fractions, so as opposed to delivering radiotherapy in 20 fractions or 37 fractions, you actually get a significantly higher biological effective dose. So you should then get a therapeutic gain. Now, there are a myriad of single center and small institution studies with this kind of dose in radiotherapy, but there's quite limited randomized data. So the only published data with full outcome that's randomized is Anders Widmark, who, as you will all know, has done outstanding studies in prostate cancer. And the Widmark study, which compared 42.7 gray in 2.5 weeks, given at 6.1 gray today, to their standard fractionation, and showed essentially that there was no difference in disease outcome, and also the treatment was very well tolerated. There was moderately higher toxicity, but very, very minimal. And this study was done with very simple conformal radiotherapy. This was not done with the modern techniques that we use today. So the study that we're running is the PACE trial. And there are 3 parts of the PACE trial. Essentially, it's looking at the role of stereotactic radiotherapy. We're comparing it to surgery in PACE A, and to conventional radiotherapy in low and intermediate risk in PACE B, and then conventional radiotherapy in higher risk disease in PACE C. So this is the schema, which is a little bit difficult to follow, but essentially you have localized prostate cancer. If you have low or intermediate risk disease and you are being considered for surgery, you can go down the PACE A arm, and the randomization there is a robotic-assisted prostatectomy or laparoscopic prostatectomy against stereotactic radiotherapy. As most of you, I think, will be urologists, you will know that randomizing between a surgical and a radiotherapy study is challenging, and the studies has been going reasonably slowly, but we're determined to see it through. So we're aiming for 230-odd patients, and I'll show you where we are in a second. PACE B. So for patients who don't go for surgery, they randomized between standard fractionation, which was 60 gray and 20, started off with 78 gray, and then moved to 60 gray after the CHIP studies published, and to SBRT. So that study recruited extremely well and is closed, and we have published the acute toxicity, which I will briefly show you today. And then PACE C we've just started. So this is a higher risk cohort of patients, men with T3A disease, Gleason 4+3, and all the patients in the study get hormones, 6 months of hormones. In PACE B, there was no hormonal therapy. It was radiation on its own. So all the patients get hormonal therapy, and then they're randomized between the same fractionations. PACE C is just opened. So our current status for PACE A, we have 10 centers open. We've recruited 114 patients, and our target is 234. As you can see, it's a challenge, but I think 114 patients is 114 more than anyone else has recruited in this setting, so we're still fairly proud of it. PACE B recruited extremely well. We recruited 874 patients. We recruited 6 months ahead of target. Sorry, we presented the acute toxicity results at GU ASCO last year in the plenary session, and one of my fellows presented the patient-reported outcome in Astro, and we put those 2 together, and it was published in the Lancet Oncology in October last year. PACE C is just opened. We've got 5 centers open. We're planning for about 50 centers opened, and 13 patients recruited. We only opened it in December. So just to show you, the PACE A accrual graph is not where I'd like it to be, but it is plodding along. We are getting there. We do get, on average, 1 to 2 patients a month. I'd like to see 4 to 5 patients a month. Hopefully, as we get more centers on board, that'll be possible. Just to contrast with PACE B, you can see it hit the very sort of exponential phase of recruitment, and we recruited well ahead of target. So the results, this was the presentation from GU ASCO, the acute toxicity results. This is clinician reported. A reminder of the schema of the study. These patients had T1C, T2 disease, Gleason 3+4 PSA is less than 20, and they're randomized between the fractionations I previously mentioned. Important to note, though, this is largely a study, although low-risk patients were eligible. In the UK, we don't really treat low-risk disease. Most of them are managed with active surveillance. And the other big recruiting country was Canada, and they have a very similar policy to us. So the great majority of the patients in this study are intermediate risk, which I think is important because a lot of the SBRT data is in low-risk disease. So what were the results? Well, we looked at grade 2 or worse toxicity, and this is GI, so gastrointestinal. And you can see that overall, the grade 2 or worse in conventionally fractured radiotherapy was 12% versus SBRT of 10%. So really impressively low results and very, very little grade 3 and no grade 4 toxicity. And the acute, that's just it graphically. You can see it comes on a little bit earlier with SBRT, but otherwise looks very, very similar. Similarly, with genitourinary toxicity, the worst grade 2 was 27% for conventionally fractured radiotherapy and 23% for SBRT. And again, very low rates of grade 3 and very low rates of grade 4 toxicity. So we were very pleased because actually the overall toxicity in both the control arm and the experimental arm was very low. And again, that just demonstrated graphically. So the conclusions we drew is that PACE-B successfully recruited, and obviously the analysis is ongoing. There was no statistical difference between the two arms. And importantly, when you compare it to previous data from a similar trial, the CHIP study, the actual overall toxicity was much, much lower. And we think this is mainly due to radiation delivery techniques, because all the patients in the PACE study had image-guided IMRT, whereas the CHIP study was only a small proportion had image guidance. So I'm now going to switch tack to one of the other things I was asked to talk about, which was oligometastatic disease, an area of huge interest in oncology. First described by Hellman and Bischelbaum in 1995 as an intermediate state between localized and widespread metastatic disease. And this is an example of some patients. And for most of us, when I started training, the role of radiotherapy in metastatic disease was purely palliation. And this was the normal Friday afternoon telephone call saying we've got a patient with cord compression, and it always seemed to happen on Friday afternoon, and we'd give them 20 gray and 5 fractions, and that would be our role in managing metastatic disease. So again, what's changed? Well, one of the things that has changed is our imaging technologies. We can now find the mets, and in prostate cancer we have the PSA, we have a marker, which, PSA gets a lot of bad press, but in fact it's still very useful in detecting relapsed disease and allows us to find these patients much earlier than we might find them in other disease types because of PSA. So we've been doing choline PETs for a number of years. We've recently switched to PSMA PET, but we also do whole body diffusion weighted MRI. But essentially we can find these patients. But just because we can see them and we've got fancy machines which I've shown you, does that justify treating them? And I was reminded of this quote by Mark Twain: "To a man with a hammer, everything looks like a nail. And to an oncologist with a fancy radiation machine, everything looks like a target." We want to treat these patients because we can, but is there actually a biological rationale to do that? Well, I think there is a biological rationale, and this is a fantastic piece of work by Gundam et al., published in Nature in 2015, where they took patients who died of prostate cancer and they mapped the genetics of the primary, if there was in situ, and the metastasis. And what they very clearly demonstrated is metastasis to metastasis spread. So we now know convincingly in prostate cancer, a metastasis can seed another metastasis. So theoretically, if you ablate that metastasis, you can potentially prevent that process happening. Sorry, I've not traveled to China, by the way, so I'm not, the cough is UK, not Chinese. Right, so this is one of the first patients we treated. He was a 59-year-old man. He was a retired plasterer, but he was an ex-professional footballer. Actually played, against people like George Best. But he obviously didn't earn the kind of money that they earn now because he was still having to work as a plasterer. He presented with a PSA of 140, and he had a Gleason 4+3 cancer. Bone scan showed no mets, and CT scan showed pelvic lymphadenopathy. Obviously, in 2005, we didn't have any other imaging modalities. He was treated with radiotherapy, and he was treated in a pelvic IMRT trial by David Dernley's team. He received 70 gray to the prostate and 60 gray to the pelvic lymph nodes, and achieved a PSA nadir of 0.04. His LHRH was stopped in 2008, and he remained PSA controlled until 2011 with a normal testosterone. This is an example of the fields that we treated. However, then his PSA started to rise, and he had a CT scan which showed a solitary lymph node about 1.5 centimeters above his previous radiation field. Surgically, probably quite difficult to access, and that was the choline PET, which showed it to be a solitary site of disease. And we literally just started our SBRT program, and David referred him to me to consider treating him with SBRT, and in fact was the very first patient we ever treated. So we gave him 30 gray and 3 fractions, and that was the CyberKnife plan, so that's what we call the hedgehog. Well, that's the hedgehog there. You can see that represents all the beam angles. And then the very, very conformal dose with a very rapid dose fall off. So you can give this with very, very accurately, and you get a very rapid dose fall off away from the target. And pleasingly, his PSA responded very well. It went down, it was, I think it was about 17 when we started treatment, and it went right down to under 1 and remained controlled for a number of years. It went down to 1.9 and then actually went under 1 and remained so. But about 2.5 years later, he developed another node, which isn't particularly surprising, and then we can argue whether you go and pick that off or start him on systemic therapy. So in this area, there are some evolving definitions in oligometastatic disease. So we have synchronous disease. So these are men who present with metastatic disease and they have a small number of Mets. Very interesting now in prostate cancer after the publication last year of the results of the Stampede study showing that treating the primary in low volume disease improves survival. So the question is, should we treat the primary and potentially treat the Mets? And we'll discuss that a bit. Then metachronous oligometastatic disease, which is what we've done most of our work in. This is men who've had radical treatment for prostate cancer or radical treatment for any cancer, and then they relapse at a later date with metastatic disease. And then an evolving definition of oligoprogression. And we now have lots of patients who are doing very, very well on systemic therapy, treatments like the TKIs, immunotherapies, chemotherapies, and they progress at a 1 or 2 sites. So that most of the disease remains controlled, but they have some clonal evolution that allows them to progress. And the concept here is, can you then go in and treat just the progressing site, allowing them to remain on their systemic therapy? And we've got a number of studies, which I'm not going to discuss today, but in both lung cancer, prostate cancer, looking at oligoprogression. So what evidence is there for doing what we do? Well, we did a review in the Lancet Oncology a good few years ago now. This was all the sort of literature that was then available, and it appeared that local control in treating these patients gave you about 80 to 90%, and about 20% were disease-free at 2 to 3 years, and toxicity appeared very low. So it was encouraging, but there is very little randomized evidence. And unfortunately, there still is very little randomized evidence, but there is some. So in metachronous disease, Pete Ost's study, the STOMP study, which was surveillance or metastasis-directed therapy in prostate cancer. So this was relatively small, 62 patients who randomized between observation or treating the oligomets with metastasis-directed therapy, either surgery or radiation. This was the organogram of the study. And the endpoint, which has received some criticism, but is an interesting endpoint, was time to palliative ADT. So these patients were not on hormonal therapy. They had had radical treatment, they relapsed, and then it was time to ADT. And they showed a significant delay in the primary endpoint. A small study, but has had a lot of attention internationally because it's the first randomized study in this setting. And I think it is encouraging, but it's by no means definitive. Pleasingly, there was very little detriment to quality of life, or no detriment at all for giving the SBRT. So I think that is really key, because if you're going to give a treatment that may actually harm the patient, then it really has to demonstrate a survival benefit. But if it actually is pretty harm-free, then you've got more margin to play with. Probably the most important study in this arena is the SABRE-COMET study from David Palmer. And this was a study not just in prostate cancer, in all tumor types, patients who had 1 to 5 metastatic disease. It was a 1 to 2 randomization between standard of care and standard of care plus stereotactic radiotherapy. And the primary endpoint was overall survival with a number of secondary endpoints, including progression-free survival. It's very important to note one thing about this study, which sometimes is missed, but not that, David's made this very, very clear in the paper that this is the way the study was designed. It was relatively small and was designed as a phase 2 screening data, and the stats around that are explained in a separate paper, but essentially the alpha was lower. So this should not be considered level 1 evidence as a phase 3 randomized study, although the overall endpoint was overall survival. This is patient demographics, and the reason I'm showing it is that prostate cancer was unbalanced. And I think it is important. Although they tried to correct for this, I think it is just important to note that in the SABRE arm, there were significantly more prostate cancer patients, and this could have affected the outcome of the study. But the outcome is still extremely provocative, because it does show that overall survival is significantly better with SABRE than the control arm. So the control arm overall survival was 28 months, when the SABRE arm it was 41 months. So despite its small numbers, despite the imbalance of prostate cancer, the results are highly provocative, and they do give a strong signal about a potential survival benefit, although, as I said, it can't be considered as a phase 3 study. So let's have a look at another interesting case. This man was 72. He presented with a PSA of 66, Gleason 4+4. His MRI showed him to be T3B and N1 disease, so you can see he had a really unpleasant, aggressive prostate cancer. We treated him with androgen blockade and then radiotherapy. He was in a different radiotherapy study at the time, was looking at hyperfractionated treatment of the prostate and pelvis. And he did very well. He achieved a PSA nadir of being undetectable. But then his PSA started to rise. He had a choline PET scan, which showed Hyler disease, unusual site. So we went on to biopsy this, and it was confirmed to be prostate cancer. He was started on androgen deprivation, did well initially, and then his PSA started to rise, and it rose quite rapidly. He had a bone scan, which showed a solitary rib lesion, and CT scan showed that densely sclerotic rib lesion, showed the Hyler lesion, and also a lesion in T4 in his thoracic vertebra. We were doing some studies with diffusion-weighted MRI. We've used this a lot now, and actually showed that the Hyler disease was active, so very restricted diffusion. Very interesting, the rib lesion looked completely inert. There was no restriction in the rib lesion at all, suggesting that it was a treated metastasis, so it had an excellent response to the hormonal therapy and it essentially died, and that the disease in the vertebra was active. So we went on and we treated both his Hyler disease and his vertebra, and we ignored the rib, and that was a difficult decision at the time, but we decided to trust the imaging and not treat the rib. And his PSA came right down. There was no change in his systemic therapy, and he remained disease controlled for 3 years. That rib never progressed, but then he did develop widespread metastatic disease and went on to abiraterone, and unfortunately now has progressed on that. But he had 3 years of disease control from just treating those 2 sites with SBRT. So pleasingly, there is further randomized data on the way. So in synchronous disease, so men who present with metastatic disease, I'm sure most of you will have heard or been familiar with the STAMPEDE study. This is now the largest study of prostate cancer. Over 12,000 men have been recruited, and has tested the current standard of care with succession of different arms, including docetaxel, abiraterone, both practice changing. And the next arm of STAMPEDE, which has been funded by CRUK, and I'll be leading this arm of the study, is going to be standard of care, again, standard of care plus SBRT in men with up to 1 to 5 metastases. It's not yet open, but hopefully will open this year. In metachronous disease, we have the CORE trial. So this is in breast, prostate, and lung cancer. It was led by Vincent Koo, my colleague at the Marsden. And it's completed accrual, this phase 2. So again, it was randomized between standard of care, whatever that standard of care was, plus standard of care plus SBRT. It recruited extremely well, again, ahead of target. This was largely driven by prostate cancer. So lung and breast, unfortunately, didn't recruit particularly well, but the prostate recruited very well. And probably the main reason is we have the PSA, did the tests, had the scan. We could find these patients more easily than our lung and breast colleagues. So prostate, it recruited really, really well. And we're hoping we'll present results of this phase 2 within 18 months to 2 years. CRUK have agreed to fund the phase 3 of CORE, which will be prostate only, and the endpoint will be overall survival. And then David Palmer's group are leading the next COMET studies, SABRE COMET 3 and SABRE COMET 10. And both of these studies are up and recruiting. And as I say, SABRE COMET 10 is treating up to 10 metastases. So bold, exciting, but at least these randomized studies are underway. So what are we going to do until then? Well, we know that there's a sound biological rationale for treating oligomets. We get excellent local control. There's clear evidence of a PFS and a signal of overall survival, and it can be done with low toxicity. But there are still questions to be answered, so I would encourage you all to recruit patients to the clinical trials, and if you are going to do this, do it safely. Thank you.